and then and our. Okay, so I want to welcome everybody. This is our visiting professor program, which is a virtual program for FIENS, the Foundation for International Education in Neurological Surgery. And today we have a very important topic for the integrity, that is the completeness of nerve surgery, that is peripheral nerve and nerve surgery, a large and growing area of neurosurgery. And Shane Tubbs is one of the great neurosurgical-neuroanatomists in the world, has trained an enormous number of us and many of my trainees in every aspect of neuroanatomy, which becomes surgical anatomy, of course. And today he's been kind enough to join us to talk about the brachial plexus, one of the most important, especially for trauma in the developing world, parts of neurosurgery, which will be more and more important in the future. So Shane, it's an absolute delight and pleasure to have you here, and welcome. Please go.
Yeah, thank you, Dr. Dempsey. Thank you, Dr. Russo. And it's my pleasure to speak to your audience today. Let me share my screen here. Hopefully you can all see that. So I was asked to give a talk, and one talk that I like to give to trainees and even younger faculty alike is on the brachial plexus as a reminder of this anatomy, especially for those who are not as familiar with it. This is a part that even the faculty that perform, brachial plexus procedures, outside of carpal tunnel release, outside of ulnar transpositions, they still bring in, their anatomy atlas and to the OR. So if you're not using it every day, it becomes something that's not so familiar to the neurosurgeon. These anatomies that we'll go over today, this is kind of a part one. So maybe in the future I can do a part two for you. So part one, I like to just go over the nuts and bolts of anatomy, not insulting anyone's intelligence, but putting us all on the same working page. After this talk, you'll be able to confidently describe all parts of the brachial plexus. A part two that I give is surgical exposures of the brachial plexus, how best to do that. But today we'll just focus on the anatomy. My email is at the very last slide, so those that watch this as a taped variety or in person, you can feel free to reach out with me with whatever questions you have at some point in the future. So the very essence, and believe it or not, many professional surgeons still forget about this, is that from the spinal cord, obviously we have dorsal and ventral rootlets. And then here in the intervertebral region, foramen, notch, we have the conjoining of those fibers to form our spinal nerve. And the spinal nerve, as you all well know, is just here in front of the vertebral artery in the cervical region. It's a very short segment that then soon branches into a dorsal ramus and a ventral ramus. And the dorsal ramus, we all know, goes to only three things: the skin of the back, the native back muscles, and the facet joints, period. The ventral rami, the much larger component, will go out and in the neck and upper thorax form the brachial plexus, lumbar sacral region form the lumbosacral plexus, and in the thorax form the intercostal nerves. So what we're focusing on today when we say brachial plexus would be the fibers from these ventral rami shown here, and specifically from the C5 segment down to the T1 segment. So that's our focus. We'll look at the very schematically drawn image of the brachial plexus. Again, not to insult your intelligence, but I think this makes it easier to understand. We know that from those ventral rami of C5 to T1, we get the ventral rami segments. We then come out and see that those are going to join to form our trunks, either superior or upper trunk, middle trunk, and either inferior or lower trunk. You get to choose. And then that line here shows you that these ventral rami and these trunks are supraclavicular. That's a very important surgical concept, that the trunks are above the clavicle. These trunks then will divide into anterior and posterior divisions. And it's important to remember that these divisions lie just deep to the clavicle. So a clavicular fracture is likely to damage the divisions of the brachial plexus. And we'll note that for the inferior trunk that we see an anterior and posterior division, and that the anterior division just continues on as the medial cord. We'll come back to that. We'll see that for the middle trunk and superior trunk that the anterior divisions come together and form the lateral cord. And then finally, all of the posterior divisions shown here will unite and form the posterior cord. And the interesting thing, and this is a very important surgical pearl, is that we name these lateral, medial, and posterior cords based on their relationship to the axillary artery that you can see here. So that the axillary artery forms this central core, and that just medial to it is our medial cord, and just lateral to it is our lateral cord, and just posterior to it, our posterior cord. And then finally, we have our 5 terminal branches. We see from the lateral cord, musculocutaneous, and half of the median, the radial from the posterior cord, as well as the axillary nerve. And then from the medial cord, we see the other half of the median and the ulnar nerve. So far, so good, right? So a very simplistic way to demonstrate that anatomy. One other thing I'll add is that most clinicians refer not to the ventral rami, but to the roots, which is confusing to anatomists to just call the dorsal and ventral roots regarding the intradural components. But you may hear these referred to as roots and not rami. Now let's look at some of the branching patterns. Obviously, C5 is a transitional stage for the brachial plexus. So we see the cervical plexus ending just at this, above this level. We see some communications with the phrenic nerve at C5. That's why with upper brachial plexus injuries, you can have diaphragmatic injury, paralysis. But we'll see that from C5, some of the branches of its ventral ramus include the dorsal scapular nerve. We also see from the ventral rami 5, 6, and 7, the long thoracic nerve. These going to the rhomboids and the serratus anterior respectively. What's not shown here is that there are multiple little segmental branches that come off of each of these rami, and they're innervating your prevertebral muscles. So the scalenes, longus colli, longus cervicis, etc. So you can even have issues with those muscles in a patient with very proximal lesions. As we move along, we'll see that the superior trunk gives rise to the suprascapular nerve and nerve to subclavius, which is clinically not so important. Suprascapular, as we'll see as I move along in the presentation, will travel to the supra and infraspinatus muscles, so important for abduction and external rotation. You'll notice that from the divisions, we have no branches. So nothing to remember for the divisions other than they lie just deep to the clavicle. As we move on, the lateral and medial cords, posterior cord. Lateral cord, we see just a single branch. This is the lateral pectoral nerve that travels to the pectoralis major. The medial cord, we see the medial pectoral nerve that travels to both the pectoralis major and pectoralis minor. And in addition, from the medial cord, we see our medial cutaneous nerve to the arm and medial cutaneous nerve to the forearm. These can also be called medial antebrachial cutaneous and medial brachial cutaneous. We'll come back to those a little later. Posterior cord has a lot going on. It has 3 major branches that we can refer to as the upper, the middle, and the lower subscapular nerves. And over time, the middle subscapular has had its name changed to thoracodorsal, but remembering the older name helps you understand its position off of the posterior cord. The superior and inferior subscapulars, these both innervate the subscapularis muscle, a very powerful internal rotator of the glenohumeral joint. The inferior subscapular also innervates your teres major, which is, again, a powerful internal rotator of the glenohumeral joint. And then, most importantly, you'll see the thoracodorsal. This only goes to the latissimus dorsi. So again, a powerful internal rotator, extender of the arm. Now, let's look just very briefly at the terminal branches, because we're going to go back through these with the presentation. But axillary nerve and radial nerve are the two terminal parts of the posterior cord. And we see axillary nerve, as you very well know, going to the deltoid and teres minor, the radial nerve to all of the posterior arm and forearm muscles, right? So the extensors of the wrist, for example, the triceps for radial. Ulnar, this goes, as we'll see again, I'll repeat most of this, to 1.5 muscles of the anterior forearm. It also innervates most of the intrinsics of the hand. The musculocutaneous to the anterior arm muscles, for example, the biceps brachii, the median nerve, going to the other muscles of the anterior forearm that aren't innervated by the ulnar, and also to multiple muscles in the hand, for example, the thenar eminence. And then we can see again, the bottom picture just shows you how if we take this schematic and wrap it around the axillary artery, we start to become a little more surgically oriented in regard to finding these branches. So the previous image is very schematic, but you should always remember that there's an intrafascicular anatomy that is important to the nerve surgeon. So you can't look at these just simply as spaghetti noodles. You have to look at the smaller subsets within each nerve, because when you're doing intrafascicular dissections, trying to peel out, for example, just the C7 components, you'll have to have this in your mind. So this gives you a little hint as to the increased complexity of the brachial plexus. And for example, in this image shows you how C7 fibers, right, will make their way down to the ulnar nerve. People forget that ulnar often has C7 fibers, and it's not shown on the larger schematics. All right, so a little more becoming more surgically oriented, we'll see that the brachial plexus and its supraclavicular part on the right side here is interposed between the anterior scalene muscle, which is cut here at the first rib, and the middle scalene muscle, which is shown here in the background. So we see the C5, C6, C7, C8, and then down here we see the T1 component. And then over the middle scalene here, we'll see that the upper trunk is beginning to form between C5 and C6, middle trunk, and then the inferior trunk. The important relationships here for the nerve surgeon is that just anterior to the brachial plexus is the subclavian artery. And if you've got injuries to the proximal brachial plexus in a, let's say a shoulder dystocia, it's not uncommon that you can have injury to the subclavian artery that's waiting to be found during the intraoperative procedure. Lastly, here a very important relationship, the stellate ganglion can be found at the neck of the first rib, and is a conjoint formation between the inferior cervical ganglion and the first thoracic ganglion. And these little connections to especially the T1 component of the brachial plexus is the backdrop, or the etiology, I should say, of Horner syndromes that are associated with lower brachial plexus injuries. So we've learned a little bit about positioning. So here's our supraclavicular part of the brachial plexus with our trunks, our roots, if you will, our divisions just deep to the clavicle, and then distally our cords and our terminal branches. So far, so good. We can also see that here a little more schematically. Also remembering our dorsal root ganglion are going to be here just medial to these ventral rami in the intervertebral foramen. And those are often seen with some of the surgical exposures. Remembering too that the CSF that's percolating around our intradural components of the plexus at these levels fuses here just around the dorsal root ganglion. So this is where you'll see the pseudomeningocele and their formation very frequently. Okay, one thing to get out of the way is that we have different variations of the brachial plexus. And the two most common things to consider, especially when you're doing physical exam and the physical exam doesn't match with what you think the lesion should be, is that in up to about half of the population, you can have prefixation of the brachial plexus. And that simply means that everything is shifted superiorly or cranially. So we have, instead of C5 to T1, you'll have C4 to C8. You can have a postfix brachial plexus, which is much less common, up to 4%, but I think that's probably a high number. But this just means everything is shifted caudally. So C6 down to T2. And this is very frequently, and this is probably the take-home message, if you would see this on a board or oral exam, is that a postfix plexus is more common with a cervical rib. So cervical ribs will be associated with having things shifted caudally. This is a drawing from my medical illustrator showing the first or the cervical rib, and you see that although this is not a postfix brachial plexus, you do see that with a cervical rib, the thing to remember is that it elevates the inferior trunk. So that results clinically in someone presenting with an ulnar nerve type of lesion. So if the ulnar nerve lesion you're examining doesn't quite match up with your physical exam, you should consider a cervical rib as the etiology. You can have other variants, for example, small muscle slips that run through and traverse the parts of the brachial plexus. This is called scalene minimus. And these variant muscle slips can be possibilities for patients that present with thoracic outlet syndrome. So compression of a single ramus, for example, is shown here, may be that it's an anomalous muscle slip and or a cervical rib. The regional anatomy, if we're looking at the supraclavicular part of the brachial plexus, so here's our C5 component, is that the nerve surgeon has to be cognizant of the surrounding structures that are often at surgery enveloped with scar tissue and a mangled anatomy that makes this difficult. But the two important things to be aware of with a brachial plexus exploration here in the neck is the phrenic nerve just over the anterior scalene. And when we've done these procedures in the past in this region, we try to identify the phrenic nerve as a first step just to make sure that it's protected and not injured during the dissection. Here you can see the C5 component coming from the upper plexus, and that can actually help you if you're identifying levels and having trouble, is to find the component of phrenic that joins here to the C5 ventral ramus. The other important nerve, because you're going to probably use this for neurotization procedures, is the accessory nerve. Spinal accessory nerve is here in the posterior triangle, very near to C5. And it can also be used not only for your neurotization procedure to, for example, suprascapular nerve, but also you usually see these little components from C3 and C4. So if you're trying to count down and figure out who's who in a mass of scar tissue, you can also use that as a landmark. So it's C3 and C4 ventral rami contributing to the spinal accessory nerve. Here's another image from the right neck. Segment of the clavicle has been exposed, and we see our scalene muscles, anterior and middle. And for thoracic outlet syndrome, you'll often transect the anterior scalene just here so that it's relaxed, realizing that when you put your scissors around this, that the subclavian artery is just behind. Sometimes the artery can even run partially through the anterior scalene. A variant that's fairly common that you should be aware of is that the phrenic nerve can have an accessory phrenic component. This is usually from the C5 ventral ramus, and you see that it's a lateral component. And most surgeons that I've operated with will confuse this and think it's either the nerve to subclavius or something else, but this actually is a third of the component of the phrenic nerve. Again, lateral to the main trunk. Here's the little nerve to subclavius that is fairly clinically inconsequential. Here we have important nerves. So the middle scalene is important because we see the dorsal scapular exiting posteriorly, and then we see the components of the long thoracic. So both of those, the nerves going to the rhomboids and the serratus anterior respectively. And as I said, usually pierce the middle scalene and run posterior to the main part of the brachial plexus. A good view, even though this is highly schematic, of the axilla is important when you're dissecting and trying to find the different parts of the plexus. This shows you the axilla is this triangular shaped region that has the humerus, and the head of the humerus is its lateral component. Serratus anterior here is a medial wall, the pecs as the anterior wall, and then the scapula with its associated muscles as the posterior wall. So this is good to remember when you're looking for different nerves and what they innervate. On a parasagittal view, we see the axillary artery, and as we mentioned before, the relationship of the cords and of the brachial plexus around it. Here we see nicely the pectoral branches, right? The medial and lateral pectoral branches as they're innervating the pectoral muscles. Now, I'd like to change gears a little bit. So I've given you a very 30,000-foot view of the brachial plexus. And now let's start to look at the individual nerves, and I'll give you clinical and surgical caveats as we move along. Long thoracic nerve, we said, is from the C5 through C7 ventral rami, runs behind the brachial plexus. So if you're looking for it, that's how to identify it. Innervates solely the serratus anterior and spans the upper 8 ribs in its length. It is unusual in that most nerves, as you'll see of the any plexus in the body, are going to innervate the muscle on its deep side. The long thoracic is unusual because it innervates the serratus anterior on its superficial side. So you have to be careful when you're exposing the nerve not to iatrogenically injure it. So long thoracic nerve goes to the serratus anterior and is a powerful protractor. If you injure it, you'll obviously, as you all well know, have a winged scapula. Dorsal scapular, we saw, comes out here just through the middle scalene, runs posteriorly, and travels to the rhomboids and levator scapula. So retraction and elevation of the scapulae is carried out by this nerve from C5. Another clinical, or actually surgical caveat, is that just superior to this, we see the trapezius muscle, and here is the levator scapula, and just on the surface of levator scapula is where we find our spinal accessory nerve. So I've seen surgeons before get confused, and they find the dorsal scapular thinking it's spinal accessory or vice versa. Usually with nerve stimulation, you can figure that out, but you could also figure it out just with the simple relationship of the nerves to muscles. Here again, our upper trunks, as we saw earlier. Dorsal scapular continues along, runs underneath the suprascapular ligament that you might have to transect if you're trying to get a little extra length here for either a neurotization, or if you have a primary compression at the suprascapular notch, this band has to be removed. We see that this is coming down through suprascapular notch. It runs around the greater scapular notch and supplies supra and infraspinatus. Supraspinatus is provides the first 15 or so degrees of abduction. Infraspinatus is your most powerful external rotator and provides about 90% of external rotation. Back to our dorsal scapular, you'll see that it travels deep to the levator scapula in this posterior view, deep to the rhomboid muscles running with the dorsal scapular artery, and can be easily found if you're doing nerve transpositions here, as some have advocated. Again, the suprascapular from a little different view, we see running just above it, the suprascapular artery that you have to be careful of because it can cover up the nerve and make for a little bit of a bad day if you injure it because of the depth to get down to the suprascapular ligament. If you have it full of bleeding from that artery, it's painful. A surgical pearl is that when you're looking for the suprascapular notch, which believe me is not as easy as just making a small little incision here. It's in a deep, dark hole, and often it's difficult to find. But if you can find the omohyoid muscle, which runs it runs much more superficial and is easy to find with the dissection, and you follow it down as inferiorly as you can go, it takes you to the medial edge of the suprascapular ligament, and you'll find the nerve just lateral to that. So omohyoid is a great landmark for identifying the suprascapular nerve and notch. Let's look at the posterior cord, and we'll see that, as I mentioned before, we give off our subscapular branches. The upper subscapular from C5 goes to just the subscapularis muscle. C5 and C6 make up this lower subscapular nerve that innervates the subscapularis and the teres major. So upper and subscapular nerves in your mind, you should think are innervating subscapularis, so powerful internal rotators, one of your rotator cuff muscles. And you should also think about, for example, with neurotization procedures, if you want a good replacement for something, lower subscapular nerve, as we've studied in cadavers before, is a good source, especially if you have a lower brachial plexus lesion. Thoracodorsal nerve, we see here, comes out, goes straight down to the latissimus dorsi, which is shown here. Again, powerful internal rotators and extensor of the glenohumeral region. The teres major and latissimus you can think of as related muscles because they both have the same functions of adduction, internal rotation, and extension of the arm. So that's a good way surgically and clinically to consider those. Here we see the termination of the posterior cord as the axillary nerve and the radial nerve. The axillary nerve is taking a distal course, and here you see it enter the anterior part of the quadrangular space, which is just here between the two teres muscles, and that runs posteriorly and takes the nerve to the deltoid and teres minor. The radial nerve continues along, and as we said before, will innervate the posterior arm, so all of the triceps will continue to innervate the posterior forearm, and we'll see that with some subsequent slides. So lots of high price real estate that's going on here in the center part of the axilla, just centered over the subscapularis muscle. And then for reference, you should remember long thoracic here is just on this superficial position over the serratus anterior, which is our medial wall of the axilla. Now, this just exposes primarily our posterior cord branches to show you this more easily. So upper subscapular, here's the thoracodorsal, and then our lower subscapular. Nice example of the axillary nerve traveling with the posterior circumflex humeral artery and through this tiny little quadrangular space. The nerve can be compressed here, so that's something to remember. Radial nerve going down, and as you'll recall, and as I'll mention probably later, that with shaft fractures of the humerus, the radial nerve is at peril. The divisions, we said this already, has no branches. It's deep to the clavicle. And then if we look posteriorly at the axillary nerve, this comes out, innervates just the two muscles that we've already mentioned, teres minor. And teres minor is clinically fairly unimportant. It provides about less than 10% of external rotation of the glenohumeral joint. Infraspinatus is the much larger and much more important muscle that does that. But for axillary nerve, obviously our deltoid with its ability to abduct the humerus, flex and extend the arm, those are very important. And then finally, and we'll mention these as we go along, the cutaneous part of the axillary nerve, this upper lateral brachial cutaneous, supplies the area, the skin, over the deltoid, and the region that has been called the sergeant's patch over the deltoid region. So an axillary nerve lesion will present usually with that type of sensory loss. Here, nicely, if you're going to expose the radial nerve from a posterior perspective, you have to find the so-called triangular interval that's just below the teres major, between the long and lateral heads of the triceps. And in that little interval, you'll find radial nerve just before it enters the spiral, musculospiral groove or radial sulcus. And here is the deep brachial artery that travels with it during that course. You can expose the triceps a little more and follow the radial nerve here. Here is at the very beginning of the spiral groove. So it's about to run from the posterior arm down towards the anterior portion of the lateral epicondyle. So that's a great surgical landmark if you're trying to identify the nerve posteriorly. Here we'll see if we follow the radial nerve distally, it comes out between the brachioradialis here and the brachialis at this point. So you can find it in this interval very quickly. And then it's soon after that interval that you'll find it dividing into its superficial cutaneous part. And then here we see its deep component. I like to still use the terminology where we call this the deep radial, entering into the supinator here at the arcade of Frosch, this little tendinous band. And at that point on, from the entrance into the supinator, we change the name and call this the posterior interosseous nerve, which we'll come back to. Just for reference, deep to the biceps, here's the musculocutaneous nerve. And then here we see the median nerve that's traveling with the brachial artery. And if we look at the supinator, so this is the posterior or the extensor compartment of the forearm, we'll see exiting the supinator muscle, the posterior interosseous nerve, right? And this is going to innervate all of the muscles that extend the wrist, and also it's going to innervate the muscles that are moving the thumb, the long outcropping muscles. So the abductor pollicis longus, extensor pollicis brevis, and extensor pollicis longus, as shown here. Here you can see the extensor carpi radialis longus and brevis, again, which it would also innervate. Here is an anterior view. So let's again look at the radial nerve. Here it is going underneath the supinator. So if you have a PIN syndrome, posterior interosseous nerve syndrome, you may have to explore that nerve by cutting through the superficial fibers of the supinator muscle to expose the nerve fully. The cutaneous branch hides under the brachioradialis and doesn't surface until here at the skin over the anatomical snuff box. So here's, just as I mentioned, the superficial radial nerve branch becomes cutaneous here, supplies this area over the anatomical snuff box that you see just at this position, and has a variable innervation, but usually the dorsal part of the thumb, dorsum of the index finger, those are radially innervated in general. Now, what I like to do to compartmentalize things, and I think this is extremely useful for studying for boards or studying for just examinations, is in general, is that think about the 3 Ps, the points of perilous passage, as I like to call them. So these are compression points or anatomical landmarks that you might have to investigate if your patient presents with compression at one of these sites. So for the radial nerve, the 5 that are at the top of the list would be somewhere in the musculospiral groove, in the lateral intermuscular septum, the muscular furrow that I mentioned between brachioradialis and brachialis, at the arcade of Frosch, And then sometimes the brachioradialis, the superficial cutaneous branch, can pierce that tendon and be compressed there as a part of Wartenberg syndrome. The medial cord, we'll talk about the branches again. So medial brachial and antebrachial, the medial pectoral, and then by far the most important, your ulnar nerve. We see these here. So here's the medial cord. Here's our medial brachial cutaneous. And then we see our medial antebrachial that crosses the elbow joint. Medial antebrachial has been used for nerve grafting. It's nice, long, and you don't have to have it. It's fully cutaneous. And then we've not shown here our medial pectoral, which would supply our pectoralis major and minor. And then ulnar nerve. Ulnar nerve is descending here, will travel through a thickening of this medial antebrachial or brachial fascia, which is referred to as the arcade of Struthers. It then enters the cubital tunnel posterior to the medial epicondyle. And as I'll show you in another picture, we'll then dive into the flexor carpi ulnaris. Here's our medial pectoral nerve, just for completeness sake, we can see it piercing the minor, and that's a great surgical finding. So if you're trying to use the medial pectoral nerve for a neurotization procedure, we've used it often for medial pectoral to musculocutaneous in birth injuries, and you can find it because it'll pierce the minor and then come up and innervate the major. So you can dissect it from this position, transect it, and then move it over very easily. There's enough length of it. You'll see the lateral pectoral nerve that comes over to the pectoralis major. And the two have a union here right around the axillary artery that I'll draw your attention to. This is called the ansa pectoralis, as coined by our group. And the importance of it is that it somewhat tethers the medial pectoral nerve to the lateral pectoral nerve. So if you want to get a little more extension for your neurotization procedure, you can simply cut this ansa pectoralis and it gives you a little more length for your procedure. And then we see the ulnar nerve as it travels behind the medial epicondyle. It travels between the two heads of the flexor carpi ulnaris. There's usually a band of tissue here uniting the olecranon and the medial epicondyle, called Osborne's ligament, that if you're doing decompressions here, it's something you have to consider. It's not always there, but if it's there, it's usually transected. Here, the ulnar nerve enters between the two heads of the FCU, and its first branch, in fact, is the nerve to the flexor carpi ulnaris, which if you're doing various nerve transfers, you can use this branch, which is a nice long branch. We've published a study that showed that it's a nice transfer nerve option. Then we see the ulnar nerve as it enters into the anterior forearm. It's usually deep to the flexor carpi ulnaris, which has been cut, and travels with the ulnar artery. So you have to be careful not to injure that when you're doing a dissection. Travels just medial to the pisiform, and then enters the so-called tunnel of Guillain, the ulnar tunnel. And then from there, its deep branch will innervate all of the intrinsic muscles of the hand, two of the lumbricals and all of the interosseous muscles. So carrying with it primarily T1 fibers for use when you're talking about physical examination. So here's the deep branch. Here's the entrance into Guillain's tunnel, which may have to be explored if you have a distal ulnar nerve problem. The superficial branch stays outside of that, and then both of those are outside of the carpal tunnel, so not to be confused with the median nerve at this level. You'll see that the deep branch takes almost a right angle and terminates into the adductor pollicis muscle. And again, this is completely motor branches. You can have communications between the deep ulnar and the median. So that's something to remember during your dissection so that you don't put too much tension on one or the other. And then here again, we see the landmark for this is the pisiform and the hook of the hamate forming these borders of Guillain's tunnel. And that has to be explored for distal ulnar nerve compression. Beautiful picture that nicely shows our deep branch here again, and you can see the pisiform, hook of the hamate, the floors, the pisohamate ligament primarily, and supplying all of these deep intrinsic muscles. And then just next door to it, the median nerve traveling deep to our flexor retinaculum. So points of perilous passage, or points of potential compression of the ulnar nerve, and we've mentioned we mentioned all of these. The arcade of Struthers, remember that's a very proximal thickening of the medial intermuscular septum in the arm. Cubital tunnel, which is just posterior to the medial epicondyle. Osborne's ligament, which is a little distal and travels between the medial epicondyle and the olecranon. Guillaume's canal, which is very distal and it's between the pisiform and the hook of the hamate. Lateral cord, so our two branches are the musculocutaneous and lateral pectoral nerves. And here we see a great distinction of the musculocutaneous nerve. The surgical thing to remember is that when you're dissecting this, that musculocutaneous lives between the pectoralis minor and the coracobrachialis. So there's a little triangular region here formed, and you can find it in that region coming off the lateral cord, and you can follow it through the coracobrachialis, which it normally pierces, and then it enters into the space between biceps brachii and brachialis. Here it is, piercing coracobrachialis, and this can be a point of compression, as I'll mention earlier, supplies that muscle, which is an adductor of the arm, supplies the brachialis, which is the most powerful flexor of the elbow, and then also, as we all know and test, the biceps, which is not as powerful of a flexor of the elbow, but is a more powerful supinator of the elbow, and then continues on and terminates lateral to the biceps tendon on the radius as the lateral antebrachial cutaneous nerve. And its point of compression is the coracobrachialis, as I mentioned, so that has to be explored if you have a proximal musculocutaneous issue. The medial pectoral nerve, we've seen this earlier, or lateral pectoral nerve, excuse me, coming off of the lateral cord, coming over usually just the pectoralis major, and it pierces a fascia that's in this region just below the clavicle. So the clavipectoral fascia that you'll have to dissect is also united to the medial pectoral nerve by this ansa pectoralis. And we can follow it over if you find it first during your dissection, and then that helps you find and identify the lateral cord, especially if you're looking for the musculocutaneous nerve. Median nerve has these two components here that we mentioned much earlier in the talk, and runs on this medial side of the arm, running with the brachial artery more intimately as you get toward the cubital fossa. When we look in the cubital fossa, you'll see that if you can identify the biceps tendon, then from that point medial, we have tendon, we have artery, and then we have nerve, so TAN, and the nerve being the most medial if you're trying to find the median nerve very proximally. Its first branches, as you'll see, are going into the pronator teres. So those are easily identified, and you can then work backwards to find the main trunk if necessary. Here, the median nerve is seen again, just in this position in the cubital fossa, most lateral from the tendon of the biceps. And then we see distally that the nerve will travel deep to this tendinous arch of the flexor digitorum superficialis. This is called the sublime arch or sublime band. And this can also more rarely be a compression site of the median nerve that's then seen distally between the flexor digitorum superficialis tendons and the flexor digitorum profundus tendons. It runs here, very superficial. If you have a palmaris longus tendon, it runs just deep to that tendon, and then runs underneath the flexor retinaculum to enter the carpal tunnel. Here we see prior to the carpal tunnel, and importantly, the palmar cutaneous branch of the median nerve that supplies the palm and is essential in your diagnosis of median nerve compression at the carpal tunnel or pre-carpal tunnel, so that if you have sparing of sensation in the palm, you know that the median nerve is compressed at the carpal tunnel. If sensation in the palm is not there, then you have to consider a more proximal median nerve injury. On the other side of the flexor retinaculum, it gives off this important branch that recurs back into the thenar eminence. This is the recurrent branch and is important, again, when identifying carpal tunnel issues. So you all know that the carpal tunnel, as seen here, here's its roof, which is the flexor retinaculum. It has 9 tendons, and they are the 4 tendons of flexor digitorum superficialis, the 4 tendons of flexor digitorum profundus, and then the flexor pollicis longus. And then the median nerve is here wedged between the flexor retinaculum and the superficial group of flexor tendons, and in a very compact area. If we open the flexor retinaculum, as you'll do with carpal tunnel decompression, you'll see the median nerve as it runs in, and then it gives off its recurrent branch here. And then we'll continue on, as I'll show you in the next slide, or actually upcoming slide. Its points of compression are going to be the ligament of Struthers. This is not to be confused with the arcade of Struthers, which is for the ulnar nerve. But the ligament of Struthers is a band of tissue that comes off of the supracondylar process, which we don't all have. So if you do have that on an x-ray, you should expect that there may be a ligament of Struthers. And if you have a ligament of Struthers, then that can compress the median nerve. The sublime arch or the sublime bridge, pronator teres, remember, has 2 heads. So folks that do a lot of pronation as part of their profession, like mechanics, for example, orthopedic surgeons, they can have compression of the median nerve at the pronator teres between its 2 heads. And then most famously at the carpal tunnel. This is a supracondylar process that you can see. And remember, if you have a band of tissue running from that down to the medial epicondyle, that is the ligament of Struthers. And in that little artificial foramen that's created, you can see that the median nerve can be compressed. This is the sublime bridge, again, just to show you that that can compress the median nerve, although that's rare. Now, what I'd like to do, that's throwing a lot of information at you, and then I like to end with a few questions of practical anatomy or essential anatomy. So questions that you can look at and try to distill and digest all of the material I just presented to answer clinical questions. So your patient presents and you think as the clinician that they have axillary nerve compression in the quadrangular space, and you have to decide what might be the finding here. So decreased adduction of the humerus, no, because the axillary nerve doesn't innervate anything that adducts. Decreased internal rotation, no, it doesn't innervate any of the internal rotators. Decreased external rotation of the humerus is the correct answer, because we said that the axillary nerve also supplies the teres minor, which is an external rotator. And then finally, the D is also incorrect. So there's no motor loss as distal to the side. All the branches are sensory. We know that distal to this branch, we still have motor branches that come off. So compression of nerves traveling through the middle scalene may result in weakened. And I'll take you way back to the beginning of the presentation where I told you that the 2 nerves that generally pierce the middle scalene are the dorsal scapular, right, for your retractors of the scapula, and the long thoracic, especially its C5 component. So if you have compression in the middle scalene as part of a thoracic outlet syndrome, then the problem will be that your long thoracic nerve is squeezed, your serratus anterior is not working, and you have trouble protracting. So the patient presents with a winged scapula. So D would be the most correct answer here. And then finally, fibers from what, sorry about that. Fibers from which spinal nerves could be compressed if something's compressed in the arcade of Struthers. So this type question makes you remember that the arcade of Struthers is a thickening of the medial intermuscular septum, and it can compress the ulnar nerve. If it's a ligament of Struthers, it might compress the median nerve. So distinguishing those two Struthers, and then knowing that the ulnar nerve has both C7, C8, and T1 ventral rami fibers. So in this question, C is the correct answer. Okay, so lots of information. I think that that's kind of a basic overview for trainees at multiple levels, whether you're a medical student, resident, or junior attending. It's always good to see things from stem to stern and review what these look like. You're not going to encounter brachial plexus lesions as frequently as cranial and spinal lesions, but when you do, hopefully some of this information will be useful to you. If you don't have questions now, I'm always available at my email, so feel free to email me with anything. I'm happy to answer your questions, and if there are any questions now, I'm happy to answer them.
Shane, thanks so very much. This is wonderful. Our audience is going to see a lot of birth injury, a lot of trauma, and this is very important both for anatomy, diagnosis, and treatment. I think one of the things you do so very well is you don't just go with the schematics, which actually for a surgeon I find harder to make sense of than the anatomy.
Right.
When you begin to put those side by side, it's just wonderful for me to think about it. And believe me, you can never learn too much about this topic. So wonderful, tour de force.
Yeah, I'd like to jump in too. I have to say that I've been at this a while, and that is the single best hour I have ever spent on the brachial plexus, which is admittedly complex. And your concept of the 3 Ps, the points of perilous passage, is something that I will retain. So thank you for continuing to teach us how to take better care of our patients.
No, thank you both.
Do our trainees have any questions for Dr. Tubbs? Sure, we will get them as we disseminate that on the website. We'll keep you informed.
Sure. Thank you for your time, and I'm happy to speak to your group anytime.
Well, we will take it up on that, but we won't wear you out, but we will spread it out over the times. Thanks so much.
Okay. Goodbye.
Bye now. Thanks again.
Sure.
Nathan, thanks very much. And if you could send